Thanks, Carole. So we'll move now to the Q&A session and open it up to discussion. Just to kick things off, let me ask the first question. And going back to the comment that Rebecca made at the end of her presentation is, what is preventing us now from building on the great work that Ryan showed in the VA system to larger networks, distributed networks, to reusable networks, and leveraging the RFD, interoperability across to really, do large, simple trials? Why aren't we doing that now? What's preventing us?
Well, so this is a version of the question, how many investigators does it take to do a large, simple trial in networks? And I think the answer is the network has to want to do the trial. And I don't think the incentives have been laid out clearly enough. I mean, one of the things that's interesting is that every successful example we've described has been one in which there's some fairly short-term, high-yield return to the clinical organizations that are participating, which is good for some of the things that we're talking about. But I'm sure that at least half of the large, simple trials that Mike Lauer has in mind are ones that a clinical organization would not see as being in its direct interest in the short term. And so, until we sort of have that frank conversation about what's needed to do the activation energy, I think we'll be stuck in this mode where Ryan makes a lot of progress with a certain kind of trial, or Carole does, but you don't, but you won't create the real sentiment that there needs to be to go over that activation energy.
So Ryan, how did you create incentives for physicians participating in the VA trial?
So for the first pilot, we didn't. We wanted to have a natural experiment to see if people would participate if we just put it there. And it turns out that people actually, their intellectual curiosity gets the best of them, and they do start to click the button, so to speak. However, that we plateaued in terms of our ability to engage providers to start to click the button. So we started to do PR efforts and education, and we saw a little bit more of a plateau. But the incentive really has to come, I think, from the medical service and the healthcare system itself. They need to drive the bus. And so I don't think that we can view ourselves as researchers and as clinical care answering two separate questions. We need to answer the questions that are best for the healthcare system. And once we all agree on what the questions are, I think the incentive then falls from that.
I mean, I think on the technical side of the equation, getting familiarity with the individual components, I think, is key before we go to the big enchilada. We are already experimenting with e-sourcing with a couple of vendors in trials that we're piloting, which we think gives us a lot of advantages in terms of getting real-time data to monitor during the course of a trial, eliminating some of the site monitoring needs because we're seeing data in real time, and moving us closer to a vision of central command center where we're looking at data from sites in real time. But we haven't yet leaped to the RFD-based, connected network type of a trial. But that's probably the next step.
I keep pondering this because I can't figure out why people won't do these. And even when I said enough demos, we're going to do the real thing. And I keep hearing, oh, there's fear of regulatory repercussions, but that seemed to go away in the last few years because of the guidance on eSource and everything, so they can't say that anymore. And the most recent excuses I've heard is that the people at the top are willing to do this and take the risk, but the minute you get it down to the people who are doing the data management, they're no longer willing to take the risk, and they don't want to change the way they're doing things. And I don't know if that's true or not, but those are some of the things I've been told.
mean, with regard to e-sourcing, we certainly have had discussions with FDA and recently had a meeting with FDA about the trials we're planning on launching. So seems to be a lot of collaboration and willingness to move in that direction. We have a couple of people at the microphone.
Josie Briggs, Bethesda. I really enjoyed the presentation, Ryan, of what's happening at the VA, but I'd be interested in your thoughts about the willingness in the VA infrastructure to use cluster randomization approaches or any barriers to that. We've been thinking and talking with various people in the VA system about the use of various complementary health practices for returning veterans, and these seem to be really ideally suited for cluster randomization kind of approaches, but I haven't felt there was necessarily willingness to grab this idea. So I'd be interested in your thoughts.
Sure. So cluster randomized trials are something that we do. In my own center, we've done just one, but throughout the Cooperative Studies program, we've done a few. And then within the realm of quality improvement, I know that there are a lot of cluster randomized studies that are done and just not published for research. So I don't get the same impression from the VA system that you've gotten that they're averse to doing a cluster randomized study. I think that everything is dependent upon the situation and who you talk to within the VA. If you'd like, we can have a discussion offline. Yeah.
Ralph. Oh, sorry, Rick first and then Ralph.
Good morning. My name is Ramana Hasnain Winia, and I direct the Addressing Health Disparities portfolio at PCORI, and I want to thank the panelists for terrific presentations. One of the things that I haven't heard a lot about yesterday or today in the context of infrastructure is how we can use these opportunities to ensure that we have the data elements to address disparities or to advance equity. I've written quite a bit with my colleague Joel Weissman at Harvard about the need for a research infrastructure nationally to be able to do this. And EHRs offer a great opportunity, but we know there are a lot of barriers. Working with multiple health systems, health plans, clinics, we hear over and over again that the administrative data don't have the demographic data that we need. Health systems don't have the data that we need to really address disparities. It's difficult to get the data into the EHRs. That may change with meaningful use and some of the minimum criteria for gathering demographic elements like race, ethnicity, or primary or preferred language. But those barriers are still very, very prominent. And there are definitely organizations out there that are pioneering and doing good work. But I don't want to lose sight of that conversation in a forum like this, because I think it's really important for all of us to be thinking about that as we go forward so we don't lose that opportunity. And I'd really like to hear what the panelists have to say related to that.
Rachel, Rebecca.
I have had some discussions with people at NMQF about that, because I think it depends on what kinds of studies you're doing as to what kind of data you want. And I believe that's some of the advantage of the flexibility of the RFD, is that you can design your case report forms to collect whatever racial information or the different types of things that you want, and then make sure that they're going to collapse into the standard categories that are shared if that's needed. So I believe it can be easily addressed if the studies are designed in a way, because you're never going to find all the same information in every EHR that you need for research. You're going to have to design it to get certain core information and then to collect the research information that's needed for that particular research question.
I think there's an opportunity for Corey to articulate a standard that particularly would allow patients to self-report that information to be included with their EHR or even their administrative data.
Ralph Horowitz. So I've always been guided in thinking about the importance of research by two criteria. Is the question worth asking, and is the answer worth getting? And this panel has, I think, very nicely sort of focused on strategies for trying to make getting the answer easier, and more embedded in standardized care. But I wonder if you would comment on the relationship between the question and the effort it takes to get the answer. I was struck yesterday in Joe Selby's group about the emphasis on questions as they are framed by patients or by physicians or payers or sponsors. And as we lower the activation energy that it may take to carry out this kind of research, we're likely to change fundamentally the kinds of questions we ask. So do you have thoughts about what the implications are for changing the infrastructure on the kinds of questions that we will or should be asking for patients and physicians?
Thanks for the question. I still remember when I was a clinical scholar that my first presentation, you were at one microphone and Alvin Feinstein at another, and I was having a bit of heart palpitations at that time. So this is an easier one for me to answer. I think that one of the things we've tried to do, and this is a bit when we've started these networks, is to start with the outcome in mind. So for children with inflammatory bowel disease, improving quality of life, getting kids into remission. And as you start to focus on those questions and develop data for that, you're then able to answer many other questions that come up that the clinicians often bring up from challenges at frontline care that the patients bring up that are important, and develop some group processes for assessing which ones you want to do. So in all of the networks, we've tended to start with the bigger outcome that we want to see, and then that leads to being able to answer many, many different questions that you might not even have anticipated at the beginning.
Certainly one of the questions I would have representing industry is how can we adapt these networks to answering interventional, investigational questions and looking at explanatory trials as opposed to, pragmatic trials, and or somewhere along that continuum, which, I guess a question to Ryan, could you adapt your system to doing an investigational intervention in the VA system?
It is something that we have discussed. However, when talking about the point of care program and kicking it off, we're talking about turning around a battleship in Boston Harbor. And I think we want to get out into open water and understand what we're doing first before we turn it around and start to look at discovery. So I think the answer is yes. I think we can adopt it and adapt it, the model. But I don't think that we're quite ready just yet from a programmatic perspective and also from an institutional perspective.
Just one follow-up to that. We've recently come out, publicly announced a collaboration with Walgreens to conduct clinical research studies across their network of pharmacies. There's probably thousands of pharmacies across the U.S. Average distance from a patient is about 3 miles, and there's about 350 that have nurse practitioner-based settings. So when you start thinking about minimalist visits or visits that only require, for instance, vital sign monitoring or that doesn't require the interventions from a tertiary care center, you can think about hybrid models where maybe a study is overseen by a standard or traditional center, but the in-between visits are actually conducted close to the point of care in a pharmacy, which is an opportunity. It's a different type of network, obviously, but I think expands our thinking about what a network should be.
It struck me when I heard Rebecca's presentation about all the hard work you've been doing for 15 years, and the standards are really well set, and the rest of the presentation is demonstrating progress we've made, that there's a major barrier to a lot of clinical trials moving into this arena. And so from industry and potentially AROs and CROs and maybe even PIs on R01 grants, that is that, say, for example, from industry perspective, there's a lot of concern about control and timelines. And a turnkey solution provided by industry is really critical to get things out the door. When you move into an environment where you're sharing responsibilities across the group, it's very difficult for those individuals to move into that shared responsibility. And I wonder how we can actually overcome that. There has to be some critical mass. But it is an awkward and inefficient system to run a classical traditional study. It's expensive, as we know, and inefficient, but there's total control. The timelines will be there. We'll have full monitoring and so on. That's probably the biggest impediment to doing that is the giving up of that. And the idea that we would be sharing responsibilities with the people generating data. And I wonder if there's a certification process or some kind of notion that can make individuals who do these big studies, industries and CROs and so on, become comfortable with that shared responsibility.
Yeah, I think that's a really good point because I think that the control of these institutional trials is a big concern. But a lot of them, and Ken has the data, don't enroll the way that they should. So the responsibility on the investigator to enroll the patients becomes something that can affect the timeline very drastically, which is, again, why a lot of people are going to overseas trials to get more patients. And my feeling is if we made it easier for the clinicians to enroll patients, then you would expand the capacity for research in the U.S. dramatically. And that was one of the rationales for taking on this last HITSB use case, was we're having a lot of our research done not in the U.S. And what would it take to allow? So the incentive would have to be that you'd have a lot more patients in an environment that, like John was talking about, that's closer to where you're trying to get the information, then maybe your timelines would even be better. So I think there's still a lot of fear about what is going to happen. I think to also bring a process context to the last question about simplifying things, I think people were really surprised to see how small the data set for CDASH really is, the required data that you really need. And I know that Dr. Woodcock and others who promoted doing CDASH feel like there's a lot of data that are collected that isn't needed. And that's the other piece, that if you could have these simpler and collect the data you need to answer the critical questions, but only that data, not, oh, but what if we need this and what if we need that, that increases the burden and the cost tremendously. So I think you need to balance the control with some of the advantages that you could get by sharing that.
I mean, just to add, we experienced some of that anxiety in entering into this collaboration with Walgreens. Obviously never done clinical research, in getting them up to speed with GCPs and just conducting trials. So a lot of little baby steps, little pilots here and there. But next year we're planning on doing a 10,000 patient observational study with Walgreens. So it's a matter of getting your feet wet a little bit and getting a comfort into a comfort zone where you're comfortable that they can actually pull it off. Center, and then
C2, Dr. Selby.
Okay, over here to Joe.
Thanks, Dr. Ferris. As I stood up, I was Joe Selby from PCORI, and as I stood up, I was going to say that we seem to keep bumping into this issue of questions and whether questions differ, and then backing away from it. But as I've stood here, the panelists and the questioners have really embraced it, so that's encouraging, and I'll be brief and just pile on a bit. It is my sense that we can talk about the questions that are of interest to the research community, and to sponsors, and questions like those that Ryan has been able to get the point of care project to address. But just an observation that I don't think, and I don't think we at PCORI feel that there's any one legitimate source of questions, that we all have crucial questions.
underappreciated perhaps by others that need to be at the table. Right now, those who are, most present at the table are the research community and sponsors. And patients are, I think we've heard, are really waiting in the wings and pretty ready to come to the table. And maybe those least prepared are the clinicians and the systems in which they work, including their CEOs. So just a speculation that it may be the research community and sponsors that have to do the first reaching out for those that aren't quite ready yet to get a taste of. I mean, I think we're all impressed that research offers an answer to many of the problems that we all face, but my speculation is that getting a taste, getting a forum where these organizations who represent individuals we need to work with, getting them at the table, it won't take that long for us to be able to find common ground and address questions of interest to us all. So I think that you could see an explanatory trial in the VAs or other systems someday, but probably wouldn't be the first one you'd start. Thanks.
Hi, Tim Ferris from Mass General Partners Healthcare System. So in a comment and a question, the comment is related to this issue of questions, and I thought Carole's and Ryan's presentations of the incentives and Richard, your discussion about what's in it for them immediately. There's clearly short-term gains. I'm speaking from the perspective of an academic medical system. Why would I do this? I participated in several research networks as the PI for Mass General, and every time an RFP or a request to participate in a trial came in, the request dramatically exceeded what we were prepared to invest in terms of our own personal investment. They came with very little money, and oh, you're part of this research network. This is a great opportunity for you. It was actually a great opportunity for the investigators to get a whole lot of data out of us, and really gave us very little. We weren't particularly interested in the question. We weren't particularly interested. The question didn't address any of our on-the-ground needs. So having said that, it seemed to me that the descriptions fell into of the different kinds of trials fell into a rather neat matrix of a process change that requires no IRB or consent, minimal workflow changes, and you can get all the data you need out of an EHR. That was some clear examples from Carole's description. And then you contrast that with an FDA-regulated trial, an explanatory trial that absolutely requires extensive IRB and consent and extensive workflow changes in the clinic. And you can't get the information you need all the information you need from an EHR. And those seem to me to represent holes in what you have described as large, simple trials. So to me, the issue is the word trial. And what are you talking about with the word trial? Because on one end of the pole, you've got something that's very doable and you could easily incorporate into clinical work. And another end, you've got something that's actually quite burdensome to include in clinical work. And there's a lot of room in between. So my question, sorry for the long statement, is so as of January 1 last year, we became an ACO that has 500,000 lives in it. There are ACOs popping up all over the place. We now have full EHR, internal administrative, and claims data on 500,000 lives. We didn't have that a year ago. We are like many other academic medical centers and systems around the country that looks very different now than we did just a year ago. And I wonder how you see the ACO movement and the use of the greater access to and use of data within those ACOs as a lever in this set of initiatives that you have.
So Rebecca, you talked about the ability to enter data from various different sources to supplement what was pre-populated by EHR. Can you address that question? Is it, how feasible is that actually to do, and what are there system or standard requirements that are prerequisites to being able to do that?
As soon as there's an EHR that people are using and it's able to bring a remote form into its environment, which I don't do that kind of programming, but the EHR vendors that I've talked to have that ready and available to go. And I think that means that you could accommodate a clinical research study. And you said trial. I ran into that myself when NIH started defining trial in a different way so that it would be an interventional trial. And the way that we've done our standards has been so that we could accommodate any kind of clinical research, whether it's observational or interventional or epidemiology. So I want to make that clear as I answer this question, but as soon as you have an EHR that accommodates those lives and you can pull in a remote form, then the pre-population of that form will happen depending on what data are in the EHR. So you just would enter in more data if there's not that kind of information in the EHR. So I'm not sure I'm answering the question, but to me that's an example of how we can expand our capacity for research with the increase in EHRs that's going on across the nation.
Tim, I'd say the other piece that I hear in what you're saying is that the ACO is a much more able organization to be able to understand the health outcomes of the people for whom it cares. And so by definition is a much better positioned to do research as well as to provide that care. 500,000 is, on the one hand, a lot of people to care for, and as a population base for clinical trials, not so large. So it seems to me that it's on the one hand transformative, and on the other hand, I think that it highlights the great potential for your ACO and others to participate in a whole array of networks. The idea of superimposed networks so that you could participate on as you see fit without having to cast your lot with a single sort of monolithic organization is quite real.
I believe this is on. Just as a point of information, some of the largest EHR vendors use proprietary data schemes, which means that if you wanted to do something like map a form into their workflow, you would have to outsource the authoring of that form to the company that generates the EHR. Additionally, as an investigator, the creation of a data mart from some of these EHRs requires expertise in programming languages that are specific to those EHR vendors. So you have to pay. So one of the difficulties in using EHR data is a real shortage of individuals who know how to manipulate the programming languages that EHRs are written in order to extract data and create data marts. Mm-hmm. So if you are, for example, talking about doing EHR-enabled research and you are funded by ARC, for example, the cost of creating the data mart in order to do a research on something like an R01, where you're getting $250,000, is in some cases going to be greater than the total amount on the grant. So you're getting 5% investigator time, 15% postdoc time, and a lot of that's because these languages and the workforce that can go in and create data systems that are usable by investigators are highly in demand and very expensive.
I think you're not understanding the concept behind RFD. So the whole idea is that there is a remotely managed form and it doesn't actually integrate with the EHR. So the whole basis behind this is that EHRs, any EHR that wants to be qualified for meaningful use should be able to create a CCD. And the CCD is the common ground. And the CCD was mapped to CDASH. If there's not the data that we're talking about, the data are entered anew and go to the research site. So what it does is that instead of an investigator entering data into the EHR and then going and entering data into an EDC, they enter whatever's missing into the EHR in the environment. But it's, and I'm not the IT person to explain this, but it's not, you don't have to hard code the EHR and you don't have to pull all the data out that you need. There's a process of entering the data for the research study once. So even if you if you enter that data into this form that you need for the research study, it prevents you having to sit down at another computer and re-enter it all.
Number of people who can do that is limited because it requires expertise in proprietary programming languages.
It requires that the EHR be able to support a CCD and the RFD integration profile. And then you go from there as to how much data have to be re-entered. So I think, we can discuss this with the experts, but it's not, that's the whole reason for doing RFD, is so that you don't have to have all that kind of expertise with the environment that you're working in.
The other consideration is that once you learn to do it for an EHR, you can use that extract to support a wide array of investigations. And so the opportunity to amortize costs over multiple uses is a help.
Microphone.
I'm Shelley Greenfield, UC Irvine. I'd like to make a comment and ask a question. And my comment is related to something that Joe said and Ralph also asked, it's in a slightly different form, which is as you expand patient populations, large simple trials get more complex because of heterogeneity of treatment effects and heterogeneity of populations. More groups added, every patient adds more complexity necessarily, and maybe less. And the second thing is quality of care, which is highly variable, particularly in surgery and devices. We're trying to deal with that through, in part through patient questionnaires, but there are other ways as well. And one of the immediate dangers, apart from general misleading results, and maybe Joanne Manson can speak to this as well in her trial, and we see it everywhere, even now, is results that don't come out the way we want them to, which is either smaller than we expect or null. And that's the result of too much heterogeneity of doctors and patients. So I wondered if you if a timing question really, as these things, as you get your feet on the ground, are you going to be able to deal with some of these issues up front before you get some backlash, or do you have to wait till you're sailing further along, start to incorporate the complexities of large trials? And let me even point the question to Ryan specifically, which is that length of stay is variable. How should we call it? It's a multivariate outcome, and it could be that insulin, the type of insulin administration, plays a teeny, if not vanishingly small part in that, and therefore there are other kinds of data that need to be collected surrounding that question. So this really gets to, is it something effective? For whom is it effective? And in whose hands is it effective? Could you respond to that?
So it's difficult to disagree with anything that you've said. In fact, I agree with everything that you said. We are collecting information on our providers as well as our patients that are enrolled in all of the point of care studies, so that we can attempt to address the issue of practice patterns and heterogeneity within the providers, the VA medical centers that are running the point of care trials, and the regions within the VA itself. So I hope to be able to give you a better answer in the coming future. But it is something that we're paying attention to. We're collecting data on it, and hopefully we'll be able to address it.
Yeah.
It does raise the question of internal validity versus external validity, and what the objective of the trial is and what you're trying to do, and to whom you're generating, for whom you're generating the data.
John Steiner from Kaiser. You know, this is a session on infrastructure, and it's easy to focus on many of the technical components of that infrastructure. But when you start to think about what questions to ask and how to ask them, it points to the human infrastructure of this process too, or the social infrastructure, or whatever you want to call it. You know, we've talked about getting clinicians and operational people at the table. We've talked about getting patients at the table. And our experience is that even when you do that, that's the start of the process, because the questions that people asked aren't always, as Dr. Horwitz said, questions worth asking. And it takes a lot of time to get to what I think of as the well-formed question, the question that's really susceptible to being answered by a large simple trial or any other kind of study design. So I guess the points I'd like to make are first that if we focus too much on the technical infrastructure and not enough on how we actually get the people together to frame the questions, we're missing a critical piece of the infrastructure for doing this. And second, that the real critical role that researchers can play, even when we don't initiate the question, is to convert those questions into well-formed ones that really are worth answering and answerable.
It's an excellent point, and I think the scope of the whole session, I think, would hopefully address that. This session here is really focused on the infrastructure needs, assuming that, you know, we are asking the right questions, but it's an excellent point. I would actually encourage people who are participating by web to submit questions if they have any. We have one question over here. Yes.
Thank you. Sally Oken from Patients Like Me. I'd like to also just bring to the attention of the group, we've been talking some about patient involvement and including that level of interaction at the point of care so that the clinician and the patient are really truly trying to help each other make good clinical decisions about what will happen next. I really want to challenge you to think about patient-powered networks. Certainly with Patients Like Me, we get asked probably 2 or 3 times a week to participate in research from academic centers around the country asking meaningless questions. You know, they simply really want, as Dr. Ferris said, they want access to our data, but they're not necessarily asking the kinds of questions that we think our patients are burning to know the answers to. And, you know, what we try to do is help our patients have the right tools to answer a question that we formulated, and that is, given my status, what's the best outcome I can hope to achieve, and how am I going to get there? That's a pretty straightforward question. And when you help patients understand what outcomes mean, you know, most patients, when you start talking to them about outcomes, they're not necessarily going to translate that into a research question. They just want to know, can I get better, or how am I going to treat this? So I think what I'd like to challenge us to think about is patient-powered networks are a novel environment. Get your feet wet with us, but give us meaningful questions to start asking our patients to answer that will help contribute to the real-world experiences of what patients are trying to deal with and how they grapple with decision-making. And I think until we get to that level of understanding in the infrastructure that we're trying to build, if we don't include them, they are not going to have the right sets of tools in order to be able to give you the answers that we need to get to the point where decision-making gets simpler at the point of care. So again, I don't know whether there's a question in there other than to say, what do you think about patient-powered research networks? We talked about control and researchers feeling like they need to control everything. You don't have control when you engage patients. It gets messy. It gets complicated. Are you willing and ready to take that risk with us or with other networks who are building? And we certainly are ready, but don't bring us questions that are meaningless to patients. Thanks.
This is an infrastructure panel, and I think you bring up the same thing that we've been talking about. Are the questions meaningful? When you collect data from your patients, and if you have them enter it into your system, or do you use some electronic diaries or anything, and do you have a way that when they enter the data, it's in a structured format that people could integrate with others or use?
You know, let me tell you, we take a lot of time and effort thinking about how we create our structures. So right now, we're actually working on a CCD-like document. So it's actually going to be a patient transition of care document, but it's using all the field from the CCD. So in fact, we should be able to integrate into the CDASH kind of format. I have no doubt about that at all. When you talk about adverse events, we have built in for our pharma clients an adverse event reporting model that actually replicates the 3500A format and gets submitted to them in that format. So we're ready. We have the engineering capacity. We have the technology smartness on our side of the fence here. We're ready to do that. We need the clinical engagement and the research engagement to say, okay, let's help you build the right systems in order to be able to talk to each other. But every step of the way, when we think about a tool that we're developing, we code it in the background against all the common taxonomies. So every bit of data that we have is coded against SNOMED or ICD-10 or LOINC, so that we, at some future point, when you're ready to work with us, we're ready to work with you. We take that time to really structure our data tools in such a way that they will be common and commonly understood, but we have to make them commonly usable for a patient to be able to enter the data effectively. And then on the back end, we interpret that in such a way that it will be effectively translatable into the systems of a CCD environment or an EHR environment. So essentially, we are trying very hard to replicate what you're doing. So,
Rob Kelly from Dig. This has been a great discussion. It's a little overwhelming, actually, to see all that's going on. And I think the next session is going to be really interesting in light of what you all have said, dealing with the ethics of and some of the practical issues there. But I wanted to take advantage of having such a great panel to sort of see what your reaction is to the impression I'm getting from the discussion. It's almost like all the troops are massed at the border. We're ready to invade. We've even done all the pre-real war exercises. The war games have been done. And it's an amazing array of things that you all in the panel have done. The problem is the foot soldiers and the corporals and lieutenants are not necessarily on board, it sounds like. So you've got all these practitioners out there who are trying to just get through the day. And, you know, we hear about our best healthcare systems like Kaiser, where with Alan Go yesterday saying if you add 1 second to their day, it's over. You've got Rich saying, let's sort of do this in a way that doesn't affect them at all. I think I hear from Carole, and I agree with it, that if you totally gear it to quality improvement and you have some grant funding, people will do it, and it's great, and they love it, and it works. But then we have a lot of other kinds of research which don't fit into that societally are important to get done, but just won't work unless the foot soldiers are somehow able to reconfigure the way their work is done. And then the target becomes the CEO or the head or the administrative head of a practice or a health system or a payer. And so I'm just trying to figure out what your view of the right target is. And I have a little bit of a lingering concern about the presentations that have been made, that they may be evanescent depending on research funding through grants. And if that's an incorrect impression, then please correct it, because we've seen a lot of these things come and go over the years. Then the final concern is you're an infrastructure group. So I think one of the great fears at almost every level about building research infrastructure is once you build it, if it's not working, it's really hard to change its course. So the cancer cooperative groups would be the example that's been most in the limelight. But if you look across the NIH, there are many networks that have come and gone over the years and have been accused of being ossified over time. So that's sort of a list of things that I'd love to hear what you think about.
Get up, Carole.
Thanks, Rob. I always like talking to you early before basketball season starts. I'm a Tar Heel, and he's not, so it's easier to talk in November. So, thanks. You're hitting on really, really important points, as usual, and the sustainability of these, I think, is key. One of the things that I didn't mention is that Of the 5 networks, we have a variety of funding mechanisms. For 3 of the networks, the sites actually pay to participate as part of the fees, and it ranges from $10,000, $5,000 to $18,000 to participate. Right now that's working. I think for children's hospitals to do that for each subspecialty begins to get expensive. But some of what we've thought is how can we leverage some of the infrastructure to decrease some of the costs now that we know what's going. Certainly things have been accelerated by different grant funding. We're using some models at the state level with state funding and federal Medicaid match to facilitate things. But I think that some of the key issues are going to be how do we, the participation fees only pay a foundational amount, and to really do some of this exciting work, how can we do that? How do we link with industry? In the ICN network, there's some very exciting things going on with personalized monitors and devices. So, you know, how do we forge some relationships there that can help this? So our thought is that these are not evanescent right now. We feel that we're building a good base, but I think the question of sustainability and really robustness is going to be key, because we can keep them going at a low level, but doing it more broadly is going to be important, and figuring out with industry, with funding agencies, how to not let these disappear.
Rob, one of the questions that was embedded there was how can we get greater engagement from the provider community, and I'm wondering whether we haven't spent enough time thinking about being patient-centric. The comments mentioned before, have we really leveraged everything we can, given that there's a greater willingness, it seems, from patients who have been surveyed to participate in research than perhaps a lot of providers? And can we tap into web-based approaches or social media to tap into that resource? And for example, this wasn't highly successful, but Pfizer ran a trial last year. It was entirely web-based, and there were a lot of logistical reasons for why there were problems with that trial, but conceptually it was quite... Yeah, that's right. But conceptually it's very innovative, of course, to consent patients over the web and enroll them online without really having any local investigators. So I'm just throw that out as a question. Is there more that we can do to pull patients into the dialogue here?
If I can just comment on that, for the record, I think leveraging patients and their families is absolutely the way to go. It's the most important thing we can do. But I think it's also important to remember that historically, people that have tried to bypass their providers have gotten into trouble, because ultimately most people, no matter what they say these days, actually like to have, whether it's a doctor or whomever they trust, particularly when they get sick. And there's a lot of, it's a schizophrenic arena, I think, right now for the provider. It's not that they don't want to participate in research. They usually feel that if they do, it's going to cost them money, it's going to slow down things, they're going to be unpopular in their practice, their administrators are going to be on them. And then when you try to go around them, even if they don't have the time, it's not particularly appreciated when a patient comes to the clinic and says, I'm in this clinical trial with Novartis at Walgreens, and they put me on this, new treatment. That just doesn't go over very well either. So I'm not saying I have a solution to it, but we've got to figure out how to get, this is not at all to dissuade people from thinking about the patient as the key, but we've got to get the providers engaged somehow, or I think a lot of types of research are not going to get done in the U.S.
Good point. I wasn't suggesting either or, but you're right.
Kathy Hartman Vanderbilt. I wanted to build on that same theme. I think as we expand our patient portals and kiosk systems to be thinking about patient input data and smart devices and applications to allow us to do that as well, that there are seamless ways where we've begun to think of the foot soldiers as specialized scheduling, forms that appear at the right time in the right place so that a provider is almost unaware of why that particular form is with that particular patient that day. And the ability to streamline finding common patients and uncommon patients is huge. Whether we do that through advertising in the community and filtering on who your health system is, which has been effective, cost-effective, much more cost-effective than working through clinician scheduling, or we do it through direct approaches to patients. So our most recent example was being able to find over 200 women a month planning pregnancies by going directly to our patient base, compared to going to providers and clinical care systems to try and find women planning pregnancies. There's just huge efficiency, I think, in being disruptive and going directly to patients, whether inside the system or filtering them out of the community, inside the system where you have their EMR.
One thing I think we need to be attentive to is how much we can accomplish by doing less than what seems really desirable. So it's big work to have a form appear in front of a clinician at the moment that care is being delivered. When we've done that, and A, it's expensive. B, you have to work with the EHR vendor who charges a lot, and it slows down the system response time for every single encounter going on in the whole network at that moment. So you have to ask, when is it absolutely critical to have a best practice alert pop up versus being able to say, tomorrow, can we find the patient and can we then reach out to the patient afterward? Or can we be prepared to find the patient when she shows up at the practice the next time, because we can use the scheduling system to do that. So part of what makes that less onerous is thinking about ways to use the system well, but not in the way that the Jetsons would necessarily do it, because those often are so appealing that we spend a lot of time and energy, and that's something that everybody's not quite happy with. Rob, I think part of the answer to your question is to take Mike Lauer's advice. Let's be prepared to fail early and often, because I think we don't know what the right answer is. If we say that we want to engage delivery systems to do large, simple trials, we have to realize that we're depending on the kindness of strangers. You just have to be prepared to accept the ways that delivery systems actually operate and tailor the research to the infrastructure that they have, and in some ways to their interest. So, and I just wouldn't be concerned about the fact that the system that we build today might not last for more than a few years. I think we should do everything we can to make it flexible and extensible so that it's not a one-purpose thing. But if we're very concerned about it being something that's durable for 20 years, I think that we'll be unhappy. And then the last thing I'll say is somebody has to be prepared to actually fund the durable infrastructure. So the fact that FDA is prepared to write a pretty big check for several years running to build and maintain infrastructure means that the marginal cost of answering questions for FDA isn't very large, and the potential to build other research capabilities on top of it isn't very large, but it has to be worth it to somebody. And I think to the extent that industry says we need to be able to use these systems to do registration trials, I think industry is going to have to figure out a way to contribute to the care and feeding of these systems.
Towards the end of the session here, but we have time for maybe
one more. I'm Jim Young from the Cleveland Clinic, and I want to reduce this down again, the LST concept, but I want to bring in the KISS concept, to keep it simple. And to me, your last statement was absolutely right on target. This is an infrastructure group. We haven't even talked about the costs of bringing in semantic-based data sets to try to help us through the complications of the EMR. And all these other issues. And to quote, our former CFO, no margin, no mission. What you were saying is absolutely it. Now, to me, it's a simple process. You pay for the research that's being done. we're going through a cataclysmic change in how healthcare is being paid for today. Much like we did with meaningful use for EMRs, where at the clinic we rake in millions and millions of dollars, tens of millions of dollars, because we're pretty doggone good at that. The payers have to start paying for this. And so if they incorporate it in the reimbursement for the health care that's provided, whether it's private insurance, whether it's CMS, whether it's the VA, whether it's the government-based insurance carriers, there has to be payment for this. Because the goodwill of all of us in the room that love to ask the questions and love to do these kinds of investigations, it's not enough. You've got to pay for the infrastructure. So make the payers who are paying for health care pay for the infrastructure.
Last question.
Joanne Manson, Boston. I definitely agree with the last point that was made, but also I want to bring up the concept of philanthropy from the public interested in these questions, and how a specific example of where this has been drawn on at Brigham and Women's Hospital. I think in addition to trying to learn what questions the public is really interested in getting answered, you also get a sense of which types of questions the public is, willing to support and really embrace. And there's a program called the Campaign for Cancer Prevention, which is driven almost entirely through social networks and Facebook. Facebook advertising, of this campaign, and there have been tens of thousands of donations to different, projects that relate to cancer prevention. And at one time, Brigham and Women's Hospital posted 5 to 6 projects related to cancer prevention that were being done at the Brigham, and provided an opportunity, to the public to make small donations. And there were tens of thousands of donations, to these projects. And we're talking about relatively small amounts given by any individual. But this certainly wouldn't take off, take the responsibility away from payers and government and other sources. But I think that there is a complementary role of the public, finding the questions the public really wants addressed, and also really engaging them in supporting these projects, and or at least getting some partial support for these projects. And I think that should be considered as well.
Great, thank you. Well, that brings us to the end of the session, and it's going to be difficult for me to summarize in a comprehensive way since we've covered so much ground, but let me just briefly hit a couple of highlights. You heard from Rich a discussion of distributed networks and Mini-Sentinel, and the potential that distributed networks offer for conducting trials as well as answering key research questions, and some examples of that. Ryan talked about a point-of-care trial in the VA system that this also, I think, gives us some insights into how such studies could actually be conducted within a closed system and the potential to expand that beyond. Rebecca described her healthcare link and RFD-based single source concepts that are ready to be tested without any regulated study actually being conducted at this point in time. But clearly there's a lot of opportunity there to support large simple trials. And then finally, Carole talked about reusable networks and focusing on outcomes, building a community, and translating that into improvements in quality and the potential that offers for addressing large simple trials. So I want to thank all the panelists for their excellent contributions, and look forward to interesting discussions later on this afternoon. So thank you very much.